Good morning, everybody, and welcome to Trauma Grand Rounds, sponsored by Northeast Georgia Medical Center. There is no commercial support for today's program. The speakers and planners have disclosed no relevant financial relationships with commercial interests. If you have a question for the presenters, please hold until the Q&A segment at the end of the talk. If you are attending virtually and have a question, please enter it into the Q&A section and we'll read your questions aloud. Also, a link to the event survey will be shared at the end of the program. For those of you who are here in person, it's that skinny little slip with the QR code that's for your session evaluation. And now it is my pleasure to introduce our speakers for this morning. Dr. Katherine Kohler received her doctorate degree from the Medical College of Georgia in 2008. She completed a general surgery residency at Wake Forest Baptist Medical Center and a trauma and surgical critical care fellowship at Emory University School of Medicine. She currently practices acute care surgery at Grady Memorial Hospital and is the Associate SICU Medical Director. She was particularly interested in the care of geriatric trauma patients, multimodal pain therapy, and emergency preparedness. And Dr. Patricia Ayoung-Chee is a professor of surgery at Morehouse School of Medicine and an acute care surgeon at Grady Memorial Hospital. She earned her Bachelor of Arts in Economics at Johns Hopkins University and medical degree at NYU School of Medicine. Her general surgery training was completed at NYU, and she completed her clinical and research fellowship at University of Washington, Harborview Medical Center. She is currently the co-medical director for quality at Grady and is the director of quality analytics and research for the Georgia Quality Improvement Program. Please join me in welcoming our first speaker up to the podium, Dr. Kohler.
Good morning. Thank you, everybody, for coming. We're going to talk today about trauma in the elderly, challenges, interventions, and outcomes. As was stated, we don't have any disclosures. And so these are the objectives that we're going to look to go through today. We want to understand the scope of the problem. What is it about geriatric trauma that we need to understand more about? Identify the patients that are at risk. Look for evidence-based strategies for how to improve those outcomes. Creating a surgical ACE unit. And then the ongoing opportunities for age-friendly care across the health system. So aging in the United States. So what we know about the population is that folks that are older than age 65, the amount of the population is expected to increase from 58 million to 82 million by 2050. Right now, it currently makes up about 17% of all people in the United States, and it'll rise to 23% by the year 2050. The life expectancy is approximately 78.4 years, and we know that this increased demand for elder care could more than double by 2050. The interesting part about these statistics that I didn't realize until I did the math is I will actually be part of that geriatric population once 2050 rolls around. So again, this is also hitting close to home. While I might take care of those patients now, I will be one of those patients by 2050. So again, falls are the most common mechanism we see in this age population. 1 in 4 older adults reports falling every year, and it's the leading cause of fatal and non-fatal injuries in that population over 65. The fall death rate has actually increased by 41% since 2012 up until current 2021. It's the 7th leading cause of death and accounts for about 25% of all trauma admissions nationally. But we do know that this is also the fastest growing segment of admission to trauma centers, and by 2050 will estimate it to be about 39% of the admission population. So just specifically looking at falls, once you have one episode of a fall, your risk doubles for subsequent falls. So while you might fall and not be injured the first time, your risk goes up from then on. There's multiple different risk factors that have been associated with that fall. And as you can see, it's a lengthy list that will need to be evaluated, because once your patient comes in the first time with a fall, you need to make sure that there are not things that you can correct or change to prevent them from having a second fall. Geriatric syndromes, another problem that we see with the geriatric population. Some of these include frailty, cognitive impairment, falls, urinary incontinence, malnutrition, hearing and vision loss, polypharmacy, and functional decline. And all of these things are just the tip of the iceberg when you're dealing with geriatric trauma. You look at the patient from the outside, you see a rib fracture or two, but all of these other things play into how their care courses across that continuum in the hospital. So again, the recognition and management can help optimize the care of these patients. Multifactorial clinical conditions. There's not just one problem with their whole system that has affected these different syndromes that you'll see. It's physiologic cumulative insults throughout their life that have led to these geriatric syndromes. So it's not like I can just say, oh, you have high blood pressure, therefore you're going to be at risk for this geriatric syndrome. It is a culmination of all the different things that happen and occur throughout a patient's lifetime. And what we do know is it's associated with a substantial morbidity in the hospital, poor outcomes. And when we say poor outcomes, it's not necessarily we're talking about death, but poor outcome from a discharge. Say they were living at home, functional, they have an injury, and then all of these comorbidities go together. The likelihood of having a discharge to not back home, i.e. a rehab facility, skilled nursing center, or something like that, goes up substantially with all of these different syndromes. And then frailty specifically. So what this term encompasses is that decreased physiologic reserve across multiple organ systems. It's why your patients don't seem to respond or bounce back the same way they did when they were 20 or 30 years old from the same level of injury. They have the impaired ability to withstand that physiologic stress. So if you look at a patient that's 20 years old and someone who is 80 years old with the same injury pattern, that frailty piece is what comes into it of why they can't respond to that stressor and bounce back the same way. So they have a higher failure for rescue rates. You might have all the alert systems in the hospital that tell you vital signs are off, their blood pressures, the middle of the night, the code goes off. Why does that elderly patient not do as well from that rescuing as a 20-year-old? And that comes back to this frailty score. How do you then concern for morbidity and how do they perform when it comes to those same injuries? And this is just that susceptibility to the stress of that injury and them not having that same reserve to overcome those injuries. So we know the outcomes are worse irrespective of mechanism. We know that older age is in fact an independent risk factor for mortality from injury. We know that frailty is a strong predictor of poor outcome, but how do you quantify what somebody's frailty truly is? And then again, neither your age or your mechanism can tell you how severe the injury actually is. A simple ground level fall, you can have multiple different injuries that would not happen if the mechanism was different for a younger patient. And again, we want to make sure that when we're targeting this population, you're looking at those evidence-based guidelines so that we can do our best to identify some of these other risk factors they have besides just their injuries, and how do we overcome those other obstacles to improve their outcomes. And so this is just looking at the numbers. Again, as I stated earlier, with geriatric trauma, we know that patient population, that segment of the population is getting larger. And as you can tell, our numbers have gone up every year. We are getting more percentage of our volume, even at Grady. You think about us in the city, that it's all, penetrating trauma. It's actually not. So of our patients, we admitted over 65, 13% to 24% over that up to that 2022 period. And of that, over the 65, 76.5 were from falls. So we actually have, as one of our common mechanisms of injury, is falls. You don't always think about them because they're not the, super exciting trauma that comes in, but they actually encompass a large part of our trauma volume as well. The elderly blunt patients have a high morbidity and complication rates, as seen in our TQIP data. And again, how do we optimize the care for those patients so that we can do better for them and get their complication rates down? So what we did again is we looked at our TQIP report to see where were the opportunities that we could intervene with. Some of the different evidence-based strategies we had targeted, and I'm just kind of going through the different things that we had already done prior to developing our surgical ACE unit. We had a geriatric triage criteria. We had an ortho co-management service. We built a geriatric guideline, and then we also had a geriatric service that would consult on our patients, but we knew that there was more things that we could do. So specifically geriatric triage criteria, what the whole goal of this is to avoid under triage. The patient comes in, their vitals don't look that horrible. The patient had a low mechanism of injury. They don't look that bad. But what we found is if they get under triage, their risk of mortality goes up. The ACS recommends for the highest level of activation for any patient over 65 with a systolic less than 110. For most of our regular trauma patients that are under 65, that number is 90. So we know that we need a higher threshold for those patients to recognize occult injury, someone that doesn't look quite as sick. The heart rate greater than 90, another big indicator that there's something going on with that geriatric trauma patient. Shock index can be used. And then again, ground level falls on antithrombotic agents evidence of head trauma, or lower GCS. And you will see that may increase your over triage rate, but the risk of missing or under triaging is so great for these patients that that's why you have these triggers here. So some of the pitfalls for triage, right? They have unreliable vital signs. They may look okay. Their blood pressure may be 120/80, but if they have chronic medical conditions and their blood pressure normally lives at 150 to 160, a 120 is a big deal for that patient. So a lot of times knowing what that vital sign in that patient can be unreliable. The mechanism of injury, like I said, the severity of injury. This is just an example of a cervical spine. There's a lot of degenerative changes or aging that happens in the neck that puts you at a higher risk for a simple ground level fall. That's all it takes. And you can have a significant spinal cord injury from that, but you may not think about that because it's such a low mechanism of injury. We recommend liberal CT scanning. The reason for that, again, their physical exam is not always elucidated that they have a problem. This patient may tell you they have chronic neck pain. They probably do. They have a lot of degenerative changes in their neck, but that doesn't mean that there's not a new fracture on top of some of those old symptoms. So you really need to make sure that you're scanning these folks at a higher rate than you would just to make sure you're not missing some of these occult injuries. The comorbidities, the physiologic reserve, those also play into a role of how well they can bounce back from the stress. So if they are not leveled at the highest activation, maybe they kind of sit in the corner for a few, 30 minutes before they're evaluated. That 30 minutes could have been critical to recognizing that problem, and they can't overcome that extra 30 minutes of stress that their body was in. Abnormal mentation, we see it a lot. The folks come in, they have some dementia at baseline. We don't know, is that altered mental status, that GCS of 14, is that actually what they are at home? Or is there a head injury on top of this that's actually affecting their mentation? So truly having that recognition that while this may seem like it's just their baseline dementia, you really have to be suspicious and have that high index of worry that there is a head bleed going on and getting those CT scans. And then again, the medications that they take. Those are high-risk problems for not recognizing a problem. They might take a beta blocker, right? So they're not tachycardic. Their heart rate may only be 80 or 90. That doesn't mean that they're not bleeding to death. And so again, knowing sometimes about what that home medication regimen is can really be helpful to make sure that we don't miss critical injuries in these patients. So speaking specifically about our ortho co-management service, what we understand is that there are a lot of patients that come in, ground level fall, isolated hip fracture. Those are isolated orthopedic injuries. They should be able to be handled by the orthopedic surgeons. But what we found out was they were best managed when we added our hospital medicine team to this. The team is specifically, that's their whole role, is to admit the orthopedic population. And so they have understood what some of those risk factors are, what things to watch out for, because the hospital medicine team is looking for bleeding things. They're looking for abnormal vital signs. They're getting that home med rec. They're doing the cardiac risk stratification so that they can get these patients timely to the operating room. Because what we do know about hip fractures, the faster they can get to an operating room and fixed, the better their outcomes are. They're using a modified frailty index plus albumin to also elucidate that frailty factor. How do you just look at somebody and quantify what their frailty is? This is a number that we use at our institution, and we'll talk about it a little bit later too, about how to quantify which 80-year-old is more frail than the other 80-year-old, because we do know that not all 80-year-olds are going to act the same in the hospital, and that's with that trying to quantify that frailty index. Again, we have an EPIC pathway to help manage those hip fractures. They have a very protocolized system. As long as you follow that pathway, everything works well, but we do have the ability to come off that pathway if a patient needs to be in the ICU for management afterwards. They have the ability to manage up into the SICU. And again, all of their patients, even with that hospital medicine team over 85, will also get a geriatrician consult as well, because they understand that those geriatric syndromes that they present with can really alter those outcomes. So speaking of frailty scores, there's a lot of different variations of trying to quantify how you determine how frail a patient is. One of the initial ones that came out had 15 variables. I'm sure as a surgeon, sitting down, trying to count 15 different things on every patient that comes in, it's not very feasible. It's very good from a specific standpoint of understanding the frailty of a patient, but when it came to feasibility for our service, it wasn't the ideal option for us. But again, it looks at, for the 15, comorbid conditions, daily activities, health attitudes, sexual function, albumin. So it's trying to quantify what things about a patient's functional ability makes them more hardy or less hardy. You could think about it that way. The modified frailty index that we use is modified 5 plus albumin. It looks at comorbid conditions, COPD, CHF, diabetes, hypertension, and whether you're independent at home or not. This was a much more functional for us as a group, especially with that originally started with that ortho co-management team. The orthopedic residents in the middle of the night are having to do these scores to determine where they go and how that management occurs. It's a much easier score for them to do based on that history. We have it built into Epic also to make it an easier answer and for the surgeons, and everybody across the health system can see it. It's in that admissions tab. It's a checkbox goes down, gives you a score, and then they have different levels of care depending on what it shows on that score. There are also newer frailty scores that are coming out that are trying to, again, quantify what makes a person less able to handle that physiologic stress. And the newest one actually is a 4 function. So again, looking at what the functional status is. Do they have baseline dementia, history of falls, nutritional status? It's trying to better quantify what that geriatric syndrome is, because it's not just, do you have a heart problem? Do you have the diabetes? There are other pieces in play that we're trying to identify. And these are just some of the studies that were done. Again, why do we use the 5? Not just because it's easier. We looked at, does it actually predict adverse outcomes in the trauma population, and specifically our patients? And we saw that it did. And that's what we're trying to identify, is the patients that are going to be at risk for adverse outcomes. And the 5-factor did show that for us, so that is why we're using it. So again, developing the guidelines. So we had our ortho teams, the isolated hips, managing those. Those patients were getting high levels of care. But what about the rest of the patients? Say you had a fall and it's not just a hip fracture. You also broke 3 ribs. They're sitting on the trauma service, and we're needing to also optimize their care as well, more so than just the ones with the isolated hips. So that was our initiation for this guideline, is how do we care for the polytrauma elderly geriatric patient? And again, it comes back to aggressive upfront will manage your outcomes in the long run. So there's an activation criteria for over 65. It's different than if you're under 65. We have an admission order set in Epic that changes whether you're under 65 or older 65. We have guidelines for when we consult our geriatricians. They're not going to be seen. If you have a 65-year-old that's a million-miler marathon runner, they're not going to need the geriatrician as much as the 70-year-old that has all of the comorbid conditions, has had multiple falls, has dementia. So we have certain guidelines for how to obtain that geriatric consult. Injury-specific guidelines. We also have differing levels. For example, rib fractures. We know a 20-year-old rib fracture patient is not going to look the same as a 70-year-old. So there's different triggers for us to say, you're over 65, you have less of an injury burden, but we know that you're going to have worse outcomes. So we're going to do different things to you, ICU care, pulmonary toilet, different management styles based on specific injury patterns. Frailty screening, we already had one built in Epic, so we're using the same frailty screening. Why reinvent the wheel when it's already there for our team to use? And again, the residents were already able to do this, so the surgery residents with the ortho can probably do the same kind of screening for this. Delirium prevention bundles. We built this in because we know that once a patient gets delirium in the hospital, their outcomes are worse. One isolated diagnosis of delirium in the hospital, one night, altered mental status, changes those outcomes. It inhibits the patient's ability to return sometimes back to that functional baseline. So if we can do things up front to prevent that, we'll have better outcomes in the long run. Nutritional assessments, again, most of these patients, when they come in, they might have malnutrition. There's lots of different factors that feed into it. So having that nutrition assessment as part of our guideline was very important to us. Swallowing screens, dysphagia screening, making sure that they weren't having aspirations before it. And if they were, how do we get that adequate nutrition into them? And then early goals of care discussions, palliative care involvement, making sure they have advanced care planning. We need to know that up front because it helps guide that management and making sure that we know who their decision maker is and how they want their care to be. So next step for us, after we had all of these things in place, we still thought we had a lot of opportunities. And that's where we decided that creating our surgical ACE unit would be important. So the ACE unit is advanced care for the elderly. And we had a medical unit like this. So we kind of mimicked what the medical side was doing for their geriatric patients in a surgical world. And the thought was if we can concentrate our geriatric team care in one unit, we could get better outcomes because everybody had the same focus because all the patients were cohorted as the same. We had a lot of support from leadership. That is a very key piece to getting any of these units built. And we used a multidisciplinary team approach. It wasn't just the surgeons, it wasn't just the geriatricians that came. This unit actually opened in April of 2024. It's a small unit. We only had 20 beds initially. We had an expansion up to 28. We've got some construction still going on, and once that construction is done, hopefully we can expand up to 36. But I can tell you 36 is still not even enough to care for all of our geriatric patients, but we felt like it was a starting point for us. So again, as I said, you can see the long list here of all the different leaders that we included at our multidisciplinary meeting. We sat in a room just like we are in today, bounced ideas off for each other's, made wish lists. This is the ideal. This is what we need to open. This is what we can have long-term down the road, so that we had an idea of what we all wanted to see for that unit. Multiple pre-planning meetings occurred. We focused on education because we felt like that was the biggest key to building everybody up to the same levels. We got to get everybody on the same playing field, what it means to be taking care of for these geriatric patients. Develop guidelines for it, an order set, how we were going to round on these patients on a daily multidisciplinary fashion. And we needed a culture change. This is more than just, I'm putting all of these order sets in place. One of the biggest things as surgeons we do, we like our labs at 2 a.m. That's not very good for a geriatric patient, right? Waking them up in the middle of the night, and then you wonder why they don't sleep and they're delirious. So there's a big culture change, and that's just one of the examples. But we had to rethink how we as a hospital system cared for these patients to optimize their outcomes. So the 4 M's, that's what you're going to hear about with geriatric care, right? What matters most? Medications, mentation, and mobility. So this is where we focused a lot of our care pathways from the different departments around are these 4 M's. And we still talk about this today. We have a weekly meeting and we ask the floors, what are you doing for your patients when it comes back to the 4 M's? So we had an admission criteria. We had nursing specific education training, the niche training. We also gave them trauma education because a lot of our nurses that like to take care of geriatric patients did not have trauma experience either. So we needed to make sure we had education on both sides. We looked at our nursing ratios. We know the geriatric population, it takes more to care for them. It can't be the same ratios as your regular med-surg floors. Having mobility techs on the floor, a dedicated therapy space on that unit is also very important as well. And looking at evidence-based guidelines, multidisciplinary weekday rounds. We round with a big team during that week so that we make sure that we're addressing all those different parts of the care, and again, that culture change for this unit. So this was our criteria. Again, anybody older than 80 could come to this floor. And then the 65s and older, we wanted something else that made them look that they would need help with their outcomes. Rib fractures, the surgery expected, that classed are for our hip fracture, so that kind of put them as easy into the unit. Severe TBIs, because we know they're at higher risk for delirium. Cervical fractures with and without spinal cords, because again, if you've got that collar on, you're really changing what that swallowing abilities are, and the aspiration risks were going to be higher. Anybody with delirium, and again, that frailty score, if you had that, you are automatically qualified to be on this unit. So this is one of our multidisciplinary rounding sheets. So we decided when we do this multidisciplinary, we wanted it to be structured. We wanted everybody to know what their role was on these rounds. It includes our APP team. We have pharmacy leads that are on that, nursing leads, our charge nurses are on that, therapy was there, and we had the case management, social work was there. We have everybody that walks through that unit every day on those patients addressing these different things. And there's a script, so everybody knows what to expect. So we can move through quickly, because to see that many people and talk about that many people, it takes some time. But when we follow the script through, we tend to be able to hit all the highlights as we go. And this is specifically the information we wanted from our nurses related to what is their mobility. We call it our get up and go score. That's the mobility screen we use. What are they eating? What's their appetite like? Are they having sleep? What's their NUDES score? That's their delirium screen that they're using. What matters to the patient? What are the barriers to discharge? So the nurse would have all of these things on rounds ready to go. So again, we can make sure that we're talking about those 4 M's on those rounds. All right. So this is what we've done up to this point. But now we want to kind of go through some of the data pieces and about why we're doing it. So here's Dr. Ayoung-Chee.
All right. So I was super excited to look at this, right? I'm like, we're doing all this stuff. It's great. I round on the floor as well. The interdisciplinary, and I'm going to call it interdisciplinary. Like I'll explain to you guys what I think the difference is. But I really thought this was going to make a difference. This is going to be great. So looking at our mortality, and I started in the ACE unit opened in quarter one of 2024. So about here. So our mortality has decreased since 2023 quarter one. that being said, and I started using the phrase eyeball statistics because I can put this into an SBC chart, but I just need it to be readable to everybody, right? Everybody has to see the data. It looks like we were maybe getting better with our mortality, and at least we've maintained. So that's kind of nice. Looking more specifically at some outcomes, acute kidney injury, we actually got worse towards the end of 2024. I was really sad about that. Looking at CODI, we're still all over the place. Grady is the blue line, and green is the GQIP collaborative. We went up as well on surgical site infections at the end of 2024. Unplanned admissions to the ICU, we went up as well. Ventilator-associated pneumonia, we went up as well. Major hospital events as a whole, we went up as well. So the question then becomes, did it not achieve what we were hoping? I think there are a couple of things and a couple of lessons I learned just looking at this data. So thank you for inviting us, because I don't know that I would have looked at it as yet. When we planned the surgical ACE unit and everything that we did not set it up to be easily studied. We did not set up in our registry that we were going to capture the patients who went to 5A so that it was easy to pull. So now I have to go back to Epic and try to figure out how to find the location and figure out a cohort. But we didn't set it up well to do that study part of the PDSA cycle. I think the other thing we realized as Kat and I were talking about it, we were missing a key part of the interdisciplinary team. The surgical ACE unit that Dr. Kohler opened up with the nursing leadership, we had to change. So towards the end of 2024, the nursing unit director, I think you had an interim for a huge chunk of the end of 2024. And so what we talk about in terms of multidisciplinary, having all the stakeholders and everybody at the table, doesn't always translate into the interdisciplinary in terms of everybody talking to each other, being on the same page, having that shared mental model. And what my suspicion is that around the end of 2024, we were missing that key part of the team. We were missing that leadership on the floors, right? Because as providers, we drive care. The nurses spend the most of the day with their patients. And I think having that buy-in, having that leadership, having somebody to really manage that system makes a huge difference. And so where are we going to go from here? What are we going to do? There are a couple of things that I'm going to share with you in terms of process improvement, implementation, and how we're going to approach this. TQIP has a guideline already. They have best practice management guidelines. And the nice part about their guideline is actually they include a gap analysis. You can't figure out what you need until you take stock of what you have. And the way that the ACS quality and safety program is really promoting use of a gap analysis is to have it done as an interdisciplinary team. So what Dr. Vassi or Jess thinks you have, if I ask your frontline staff, do you think you have this? The answer might be a little bit different. And making sure that everybody's on the same page about what you have and what you don't have is really important. The gap analysis that comes with the TQIP best practice is pretty good, but it's a little more high level than some of the nitty gritty you might have. So I would recommend going through the best practice and maybe making like part 1 and part 2 of some of these guidelines to say, do we have it or do we not have it? Or are these parts of what we need? And then having an education plan for implementation. These documents are long, like more than 5 to 6 lines, and I'm already like, I don't understand how we're going to do this. So the thing you really want to do is figure out what can you bite off? What is the lowest hanging fruit and what's going to be the most effective? The best example I can think of this is we started our spinal cord injury, I'm going to call it program. It's 4 years in and I still don't have a name for it. But back in 2021, we had an MOU with Shepherd, and we went over and we visited and we saw everything that they did at their rehab center for their spinal cord injury, acute brain injury, and we came away floored. We don't have as much money as Shepherd has. We don't have as much resources, but what we came away with was a core group of people who were really interested and passionate about doing better for this population. And what we said was, the least we could do is meet once a week. At the very least, what we could do is meet once a week and try to replicate that multidisciplinary, interdisciplinary meeting that Shepherd has for their patients. And so that's how we started in August of 2021. And we're still meeting weekly. Actually, we meet twice a week now. Once for the ICU and once for the floors in 2025. But it just started with, what could we do? What was the lowest hanging fruit? What was the easiest thing? What could we commit to? And who could we get in the room? And we actually started that meeting not with all the stakeholders, because we were committed to only having people who were passionate about that injury. So when you start, or if you already have an age-friendly group, and I'm going to talk about alignment and how to get this going a little bit, make sure you have the right, not just the stakeholders, but the right people representing those stakeholders. And the way I look at it is, if I don't have somebody who is as passionate as I am, then I can hold off on that stakeholder for a bit, because the worst thing you can do is mandate that somebody be at this meeting and they're not interested, and you don't get that interdisciplinary relationship back and forth. And sometimes it's easier to go without than go with if it's not the right person. And eventually you'll find the right person. So how do you actually get the hospital to buy into all of this? Well, CMS has helped us, because nothing moves a hospital like money and CMS mandates. So in 2025, CMS started requiring age-friendly hospital measures be reported on and committed to. The nice thing about this is that they partnered with the American College on their geriatric surgery verification program, so they all align. And so it should be easy to try to parlay into those resources. The meeting that Dr. Kohler mentioned, so I think it's monthly with Dr. O, it is because we have to report on these 2025 age-friendly hospital measures. And it's not that difficult. It is still based on the 4 M's of age-friendly care that has shown decreased readmissions, decreased ED utilization, improved long-term outcomes. But it's based on these 5 domains, So you want to make sure you elicit the healthcare goals, ensure patients have goals and treatment preferences for their decision-making. You want to make sure that you have responsible medication management. You want to make sure that you have some sort of frailty screening and intervention. You want to look at their social vulnerability. And then you want to make sure that you have age-friendly care leadership. I would say, not throwing stones, but you probably would benefit from having an orthopedic surgeon join, or somebody from the hip fracture pathway join, just because that is a huge part of our population. So thinking globally, either self-invite to the table, or talk about who are they getting together, how are they meeting, because I assure you the hospital has to be having one of these, because it's a requirement for payment. And then looking at the optimal resources for geriatric surgery from the American College, not saying that you have to apply for the program. I'm not here to promote the ACS, but seeing where it all lines up, because it gives you a little more political capital, well, a little more sway to say, hey, listen, these are the common things across the 3 verification programs that are out there, 2 that we are committed to, 1 because of CMS, 1 because you're committed to a trauma center, making sure that you're crossing off all the requirements across all 3 tends to get you a little bit more buy-in when you're saying it'll affect a lot of areas around the hospital.
Just some ongoing improvement projects that we're talking about of what comes next. One of the things we realized, again, when you come in for that initial triage trigger, you have a different set of vital signs, but in the hospital, doesn't matter. As long as you're not a pediatric, our EPIC order set is the same set of vital signs. So we're realizing through some of our failure to rescues, there were probably opportunities to recognize that the patient was in distress before. So that's something we're looking at, to notify our providers maybe at a different threshold. Obviously, we'd like to increase the capacity of our surgical ACE unit. We will hit there's going to be a roadblock, right? There's only so much physical space for it. So the next part of that is, if I can't put everybody in the same unit, how do I get that age-friendly care across the continuum of the hospital? Our trauma patients end up on at least 5 different floors throughout the hospital. And like everybody, we live at capacity. It depends on the day of the week of which floor you might be able to get a place to. And so what we're looking at is that niche training that we did for our nurses for our geriatric units. We are now doing it across the entire continuum of the hospital. We're expanding that to all nurses as part of their education, so that whether you take care of geriatric patients on a regular or you might get that overflow patient, you have some of those resources and an education piece to it. Increasing our screening and delirium prevention. That new death score, that's not something that shows up on every nurse workflow unless you're in those geriatric units right now. The plan is once we go live with the hospital-wide age-friendly care, you're going to see that auto pull up if you have a geriatric patient, so that everybody has had training on how to do this, and then we're going to start doing those screens and make it much more, this is the expectation of when you're taking care of a geriatric patient. Because again, that delirium prevention is key for these patients. How do we improve mobility? What we use right now is a mobility score. There's a different screen for our ICU patients versus on the floors. The nurses do the screens, but we're really empowering those nurses to move the patients. How do we get the right ratios with mobility techs, having our PT and OT folks there as well? How do we build out that mobility piece? And so that's another opportunity that we see in our hospital population. And then, as I said, extrapolating some of these things of how we change that culture for how we care for those geriatric trauma patients. Like a full hospital, if you're admitted as a geriatric patient, you sit in one of our trauma bays, they have no windows. They don't have days and nights. There's zero ability for them to understand what that time frame is. How do we extrapolate what we know about that prevention for delirium to those other locations? Even if something as simple as the ICU, you have a patient that's not critically sick for bleeding concerns, so why do I need their labs at 2 a.m.? As a surgeon, that's when I want them, so I have them for my morning rounds, but maybe I should do them at 10 p.m. so that I don't wake the patient up for those lab draws. So trying to get that expectation out there. How do we do their scheduled medications? Why would I want to give Lovenox to somebody at 4 a.m. just because that's when it timed in Epic? How do I reschedule and retime some of this stuff to try to preserve that sleep? So again, those are some of the things that we're working on to try to improve some of the care throughout the hospital. And then in summary, again, our Golden Girls. Sorry if y'all didn't notice some of the famous folks that I was throwing in here. Again, I feel like that just kind of shows how old I have gotten, as that these folks were from my younger years. But we know that there's an increased need for geriatric specific trauma care. We know that patient population is just increasing. As our population in the United States ages, so does who shows up in our trauma centers. So we need to create that space that's focused on the geriatric trauma patients. How do we use that knowledge to care for them specifically? And then again, continuing to have multidisciplinary projects. How do we as a team fix this problem and treat these patients is the ultimate goals. And that's what we have today. Questions? Yes, so in our Epic pathway, our order set for that unit, we do have pieces to the delirium bundles. There are also medications for sleep that are in that area that they can pick from. There are, once you get delirious, medications we recommend, but it even comes back to choices of medications for pain. So we all know that trauma patients have a ton of pain. We have a different multimodal order set for under 65 versus older than 65, trying to target less meds that will cause issues with delirium. They're lower doses. We have some that are less sedating in that protocol. And again, you can, once you get the patient on the pain meds, you can titrate up. But we do have different pieces in that order set to try to do some of that prevention. And again, it comes back to, for me, is how we change that day-night schedule in the hospital for those patients.
Yeah, I think melatonins pre-checked for the 65 and over in the ICU. I can't remember on the floor. Kat's still working on getting us lavender diffusers throughout the unit.
Figured lavender baths at night. We also have talked with the nursing staff, like, I know it sometimes works in your workflow better for that 4 a.m. bath, but that patient then gets woken up at 4 a.m. in the ICU for that bath. Can we optimize the patients that are geriatric to get daytime baths versus nighttime baths?
Getting enough chairs to have them sit in the hallway so that we can keep them awake during the day and keep an eye on them, try to decrease the restraints and stuff like that.
Yeah, the Geri chairs that we got, they're recliners that have a tray table that slides in. That keeps you in your chair, but doesn't tie the hands down. And we see much better outcomes from a delirium standpoint with those devices than having to restrain with the wrist restraints.
Have you found any correlation between anesthesia and recovery we do see sometimes our patients post anesthesia surgery getting into trouble within the first 24 to 48 hours, hypotension, respiratory depression, and they have a rapid response called. And I know there's anesthesia guidelines for geriatrics, but I wouldn't know how to approach that.
Right. And again, I think it comes back to the more data that you can show on your end of getting that cohort of patients and saying, look, we have this number of patients we've had this many problems with, and trying to approach it from that standpoint. But what we did, we had same problems, right? A patient would hit the floor, 24 hours later, they're getting that rapid. They might have a drop in their hemoglobin that wasn't recognized. We've tried to make a set of guidelines for intraoperative things that occur and in PACU for our anesthesia and the Team W with the ortho co-managements, where we see it a lot because they're not our primary patients. They're triggers. If you see pressors being given during the case, or you had to give blood, or you're worried about this patient, you can call one of our ICU attendings straight up. This is the number that they have, and you can get an admission to the ICU. There's no questions asked on our part. If you hit a trigger, we call, we say yes, and there's a bed for you. And then we have a team that comes to the PACU and assesses them down there. They'll stay in the SICU service while they're in that level of care. And then when they transfer, they go back to that hospital medicine team. So that's how we've tried to address that, is with some of those intra-op triggers. Because for an anesthesiologist, I needed a little neo. Maybe it's just that they were on gas. But what we found is that they were probably actually losing blood in that thigh that they couldn't see when they were getting their femur nailed, that we actually needed to be a little bit closer monitoring afterwards. And so those triggers for anesthesia has been really helpful.
To your question, though, and thinking more on the preventative side, we just started talking about, can we take some of that pre-admission testing mentality of how do I optimize prior to the elective surgery and bring it inpatient? It's not elective surgery, but it's not emergency that I'm rushing to the OR. So similar to the sepsis patients that we, instead of going straight to the OR, we took a little bit of time, resuscitated before we went to the OR. What can I do to optimize the respiratory status? What can I do to optimize the resuscitation, the taking what we do in the ICU, right? Because we don't send patients to the operating room with ortho for 10 to 12 hours unless we know they've been resuscitated. How do we take that out of the ICU and bring it to the floor for the patients who aren't as obviously sick, but are still having a different physiologic baseline? And then where do you start is, who's your anesthesia partner? And it's easy to say who's the anesthesia liaison or at the attending level, but it doesn't necessarily have to be, right? Like, we have a lot of CRNAs at Grady. And so one of my best partners actually has been one of the lead CRNAs who's really just passionate about making it better for patients and making it easier for her staff. And so that's who I partner with more than anybody else. I love my anesthesia attendings, but she's at the front line. She's the nitty gritty. She hears all the complaints. She hears all the whispers. And that's who I always want to get my info from. And then just pick one thing. Even if it's just, if respiratory is your biggest issue, talk about what do we do before the surgery, right? You usually have an overnight, a day. I think the hip fractures our PBP is 48 hours, I think, right? So you have a day built in. Do we say, hey, we're going to commit to IS pre-op for all of these patients? We'll adopt the ICOF bundle, and everybody who's going to have hip surgery has a mandatory ICOF bundle beforehand. That might change your post-op respiratory, because we've quote unquote prehab them a little bit, or at least figured out where their pain points are going to be post-op. But it can be something as simple and quick and as easy, and just that's how you start. Do better than us and set it up well so you can study it. But once you have a little bit of pilot data, that's how you then show, okay, we should expand this. This actually has some teeth and some legs to it. And it's not that hard, because I think ICOF is mostly just IS and pulmonary toilet. So it's pretty easy. And it's easy for me to say. It's the implementation of the maintenance that all of that's going to be local. So that's going to be who you get to buy it, how you set it up in the day. Jen, I think who's it for my providers in here? Frontline. Yeah, how do you make it part of your workflow? The interesting thing is, for the rib fractures that Kat's talking about, we ended up adopting the PIC score, the pain incentive spirometry and cough score. And it took off like wildfire. I couldn't tell you how we did it, why it took off. Like I never had to do a whole lot to implement it. It just everybody did it. And I finally asked one of the residents, I was like, what's the deal? How did like why is PICC so easy for everybody? Because you still have to look up the table, you have to get an IS volume. And he's like, because it took the thinking out of it. Instead of having to hem and haw and figure out, well, do they eyeball well? Do they look like they need intermediate care, or could they be okay on the floor? We set PICC scores to levels of care, and that was it. You had to be admitted to this particular unit if, well, it wasn't PICC scores, but they changed it into PICC scores, which is fine. They're doing something. But then you can downgrade from the ICU and you go to either intermediate or acute care based on the PICC score, and then you can downgrade and then you can discharge. So it just made it took one less thing for them to like try to suss out. And that's how it got adopted. So I think the thing of how do you make it easy and how do you make it work into the workflow, and that just comes from your front line.
How big a problem do you guys have with ED length of stay kind of getting in the way of these pathways? Because I think that's a huge challenge for us, because if you don't, I mean, you can have all the great programs in the world, but if somebody's stuck in the emergency department for 18 hours waiting on that specialty bed where they're going to get all these things, I think that plays a huge role in you know, getting somebody a good head start. Because once you, like you said it about delirium, but I think it's true about in-center spirometry and prevention of pneumonia and all the recovery things that you have to do. Mobility. I mean, yeah. Once you start down the wrong direction, you're kind of hosed.
Yeah.
Is there? Have you guys been successful at incorporating some of these measures during that dwell time? Because I imagine you're having a similar problem as everybody has about people not getting the
and I think
bed that they need immediately.
One of the big things is, again, our admission order sets, when we put them in, they go live. We've tried to encourage our trauma bay nurses to like live in those already. I know I've seen speech therapists come down because, again, if you're geriatric or you have a collar, you're getting a swallow screen. I've seen them in the trauma center doing those swallow screens. We try to assign our team. We have a ground floor team that has residents and APPs, that these are your patients. We have an observation unit that we can kind of get them to that looks more like a medical surge floor to some degree, to try to start treating them like they're already in the hospital. But to your point, again, it's very difficult to do a lot of the things that you do once you're inpatient downstairs. But I think those are the big things that I've seen, is really having that ground floor team that takes, this is your service of everybody that's on our ground floor. They're assigned a APP or a resident that writes the progress note for the day, that makes sure they're doing those orders. And again, it happens much better in our observation unit, which is kind of across the hallway from the trauma center. But I think still the goal is, even those patients that are still in the trauma center, that there's an ownership of a person assigned to that team that rounds on them and should be doing those things. But that's the closest I think we've come. But yeah, we're holding hours. It's not as bad as it used to be. Because we built some extra beds, but then we filled all the beds and there's more patients.
It's only ever one midnight, not two midnights anymore. But I think your question is, how do you flip that mentality, right? Because when I'm covering the trauma bay, my mentality is different than when I'm covering the ICU versus when I'm covering the floor. I have sort of different focuses, and that's, you know, I call it my outfit changes, but it's sort of just that difference. It's definitely not perfect. I think a couple of things that have helped is, in our trauma center, it's 15 actual rooms. And what the nurses tend to do is, there's certain rooms that have the longer term players, the people who are inpatient and boarding. There are two rooms 14 and 15, that are ICU boarders. So they will move patients into the rooms and sort of change that mentality of, when I'm watching these two beds, I'm no longer in active acute resus mode. I am in, we're maintaining mode. They are actually better than the provider team at saying, hey, I don't see my Q6 hour labs and this is an ICU patient. Where is it? Getting that leadership, the charge nurse buy-in of, we don't have what we know we need for inpatient, has been really good. And then what I think really helps is, for speech and physical therapy and occupational therapy, they're really being held to the metric of seeing their consults within 24 hours. So they're not necessarily physically seeing everybody, but they're chart reviewing and triaging and doing a much better job of, like, even if they are in the trauma center, not in one of our inpatient units, I still have to go see them because of X, Y, and Z. And then because everybody's about throughput, reaching out to them and be like, hey, listen, as soon as you see this person, I can discharge. Having that communication between the provider team and the ancillary services is also key, because then I can sort of move the ball and get it rolling. But figuring out a way to have either a room designation or a way to visually cue in, hey, this patient's no longer in that acute phase, we're now in inpatient maintenance phase for your boarders, might be a way to help, because it's hard to figure out the boarding time. And then in terms of waiting for the specialty units versus like the board, like getting them into a specialty unit versus the board time. The anecdote I have is when we started spinal cord, we actually got buy-in to have 2 of our units be our spinal cord designated units. 2, because we figured between the 2 of them, we'll find a bed somehow. What we ended up doing is realizing that, throughput is a little bit more, well, we prioritize throughput then over the unit. And so we would just have patients get out of the ICU so we can free up an ICU bed. And the next day talk to our bed board and say, hey, listen, this actually is a spinal cord injury patient. The next bed that frees up on 6A or 6B, can we transfer? To us, that was creating the throughput and prioritizing that was more important. And then accepting the transfer and care from one unit to another, with the cost of cleaning and the rest of that, was worth getting them to the specialty unit afterwards. So not ideal, because you had a couple more transitions, but it was just the way we could make it work to get everything that we needed.
I think that's one of our bigger challenges. We use it. I mean, we use the entire PICS cord. We use incentive spirometry to cohort patients in the ICU, IMC or floor status. And I mean, we've got limited IMCU beds. And so, I mean, and those beds are in such high demand, because that's our step down unit from the STICU. We have to decompress the unit. There's always STICU boarders that are IMCU status that are waiting on those beds. We've always got ED boarders that are IMCU status that are waiting on those beds. We could use a whole floor of those beds and be able to cohort people a little bit better. And I think we could incorporate a little bit wider range of patient in that unit, so that we're not just like pressing all the other patients into less beds, that we're actually kind of finding a happy medium between who we put in that unit and how big the unit is. I think that's an opportunity for us. But we do have the teams that are assigned to that level of care for rounding, see those patients while they're in the ED. It's not just kind of the on-call team or the whatever that, sees those patients that may be there for several hours. But we also, institute those admission orders, and they're active right away. But it is different. The nursing level of care is different, because they have different challenges in the ED. And, cohorting patients actually, to cohort patients better actually might negatively impact your ED length of stay and your ICU length of stay and all those things. So, yeah, I mean, it's definitely when the place is full, one thing you do affects everything else.
Yeah, sure. And our way around that was just accepting some of the bed swaps that we were going to see afterwards, just to redo the cohorting once we cleared up what level of bed. And it takes a lot of good partnerships and good communication with your nursing leaders to know, right? Like, so it's a communication of what level of beds do we need most for the ED boarders, and that's the unit we clear up first. And what, deciding, sometimes I have to look at the ED and be like, hey, listen, you guys are going to board longer because I have boarders in PACU and I need the ORs to run. So you just, and it trying to maintain and promote that level of transparency of what else is going on in the house helps people accept a little bit more, I've found. But yeah, the back end shuffle, sometimes it's a little bit of a doozy. Just depends. Like the spinal cord injury patients, again, we've decided they're important enough. We're going to do all the back end shuffling we have to, if we have to. To talk a little bit about IMCU beds, we actually almost try to never put our spinal cord injury patients in IMCU, unless there's something specific they need in terms of vital signs monitoring. So we were able to bring everything they needed to the acute care floor because we have those 2 units. And sometimes figuring out whether you actually need IMCU or what it is that we're putting the patient in the IMCU floor for, and figuring out if I can replicate it somewhere else was also it changed.
Yeah, that's definitely a critical. That's a thought and a question that our ICU teams consider every day. You know, if someone on Monday, when you see them is ready to graduate from the ICU, but they still need something specific for the IMC, that doesn't mean that when they don't get the IMCU bed for 24 hours that they still need it.
Yep.
So we try to think through that question on a daily basis when we make ICU rounds.
Yeah, it's totally very.
And IMCU rounds as well. You know, that's a critical thought process. Obviously, we don't. You know, we're one of our metrics is unplanned ICU admissions. So I mean, it's like you know, how do you balance discharge patients quickly, appropriately, and avoid readmissions? Same thing for the units.
Yeah, I think I don't know if you can avoid it. One of my colleagues, a good friend, has a saying: "Don't become the monster you're fighting." And he does a lot of quality work, and it's a great slide. It's a great saying, and it talks to how do you define quality, right? What is quality? Yes, we have all these metrics. To me, it's become the thing that you do irrespective of who's looking and who's measuring and who's watching. All that to say, if by all our criteria, you were supposed to leave the ICU and you came back to the ICU, right? Whether you coded or something, to me, we rescued you. Yes, we'll look back and see if there's anything differently we could have done, but there's nothing differently I could have done. Then I'm okay with that.
Right.
You know, one of my friends was like, well, how many CODIs are okay and how many CLABSIs are okay? And I was like, yeah, there's some metrics and some ratios we can do about length of stay and the rest of that. But I would be okay if every chart I reviewed, I couldn't find anything different to do. If you needed that central line, if you needed that Foley, I'm good.
Yeah, I use the phrase "teaching to the test." You know, you don't want to manipulate what you do just to make your metric look better if it's not providing better care for the patient. I feel the same way about that for sure.
You have to balance that with the payments that come with some of the metrics. But yeah, it's just I'm okay if you need that central line. It's funny, I was rounding with the infection prevention specialist yesterday, and she's like, I keep getting pushback about this PICC line, but he's on TPN. I'm like, well, tell them unless they create another formula for TPN, we're stuck with the PICC line. I don't know what to tell. I'm like, I don't know what to tell you, but it is what it is. I mean, you can throw them a bone and say, well, I talked to the team and the patient's only going to need TPN for another week. But it's just at some point, don't become the monster that you're fighting. And if it's what's necessary, it's what's necessary. Now, if it's not necessary, right, like the flip side of that coin, and Kat knows this, I'm always asking, okay, sure, we used to think it's necessary. Is it still necessary? Is the flip side to that. And so it's always this, I call it the Goldilocks, right? You're always trying to find the just right, living on the edge a little bit, but yeah.
Excuse me.
Mhm.
I want to look into is length of stay for some of those interventions, because that's probably going to be the most likely to change. Because I know from our standpoint, from the Geriatric standpoint, I feel like there's a lot of chicken or the egg phenomenon where, yes, they've got to decline within the next year if they have an episode of delirium, but some of that's the fact that they got delirium because they're just not well in general, and the family says, well, they do great at home. Yes, on a very strict schedule, and they've been walking back and forth to the bathroom and the kitchen. That's it. But yeah, there are definitely times when prevention makes a huge difference as far as overall outcomes. But in some of these instances, it's you might change the length of stay before you're actually going to change your like mortality and complication rates.
And to that point, that's what Trish was alluding to. When we set up that 5A unit, we didn't set a filter to pull the patients that were admitted to that, 20-bed unit. We're pulling all of our Geri data across every unit. And so I can't tell yet until I get somebody who can filter for me better. How do we see, is that unit the difference in that length of stay piece and the things that we're doing versus the whole house that's not doing those other interventions? So again, we still have some data digging on our end to see if we're changing any of those metrics with that isolated unit too.
One of the biggest benefits is having a dedicated case management social work group, because then they become really savvy in how to do these discharges, whether the insurance companies, the setup, the putting in the referrals early, just really getting those pieces done. Again, spinal cord, I had one social worker who was just so on it. Her first note actually was templated and laid out all the questions we would need. Do you have stairs? Is there a ramp? Who can you, she would just get all the information up front. So even if that spinal cord injury patient was intubated and on presses, she knew everything about what their home life would look like so that we could start the discharge planning, knowing what they were going to. Families could start looking for apartments that were more wheelchair friendly early on. It was just, it changes the whole game if you have social work and case management who are on top of that and know the living situation so that you know what you have to plan for.
Okay. Thank you.
You do have this too.
Thank you for having us.
Bye.